The Centers for Medicare and Medicaid Services and other healthcare payers have increasingly been testing alternative payment models that provide incentives for hospitals and physician groups to reduce expenditures. In April 2024, CMS announced the newest iteration of its bundled payment programs. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Joynt Maddox, an associate professor of medicine at Washington University School of Medicine. Dr. Joynt Maddox has co-authored a perspective article about the transforming episode accountability model. Dr. Joynt Maddox, could you start by explaining how bundled payment programs work in general?
So bundled payments essentially create episodes of care, and those can be 30 days or 60 days or 90 days, and ask a provider, typically a hospital, health system, or physician group, to take accountability for all of the costs of care and potentially quality and outcomes of care over the course of that bundle. So you can think about it as, instead of just being responsible for what happens within the walls of the hospital, taking on responsibility for the entirety of the hospitalization and then some chunk of time after that hospitalization as well.
And then what types of bundled payment programs has CMS previously implemented?
So bundles have been of interest for years. And actually, you can think about the DRG system, the way that hospitals are paid for all hospitalizations now, as being sort of the precursor to bundles. So when hospitals were first paid, they were paid for every little item, the lore of getting paid for the Tylenol and every single thing that happened in the hospital. And then we moved to pay hospitals for the entirety of a hospitalization. And so this is moving one sort of step beyond that. It had been tested decades ago for things like coronary artery bypass grafting surgery as sort of one of the first places where this was done in some small models. Now, more recently, post Affordable Care Act, as these models have become really part of CMS's portfolio to try to reduce costs and improve quality, they were tested through first the Bundled Payments for Care Improvement Initiative, and then after that, the Bundled Payments for Care Improvement Advanced, BPCI-A, as well as a mandatory bundled payment program called CJR, or Comprehensive Joint Replacement, that was focused, as the name would suggest, entirely on joint replacements. And so those have been three prior programs that CMS has successfully implemented over roughly the last decade.
You say in your perspective article that although bundled payments were widely anticipated as a promising component of payment reform in Medicare, they've actually had mixed results. In what ways have outcomes been disappointing?
So I think there's been a couple things about them that have been less successful than people had hoped. The first is that they simply haven't led to major savings. The savings have been not zero, but pretty small. So on the order of a few percent generally in the programs overall. And those savings in Medicare payments, so a reduction in the amount of money that Medicare is paying out in the bundle, have been really dwarfed by the rewards that hospitals have received as part of the ways that the programs are designed. So the net effect on spending has actually, in general, been that CMS has paid more for these programs rather than that there has been meaningful savings. The other part that's not captured when Medicare thinks about its payments is the spending that hospitals have done, either to implement programs to reduce costs or improve outcomes, or to pay consultants to tell them how to implement programs, or to pay consultants to tell them how to game the system through better coding. So I think there's really been quite a bit of administrative burden through some of these programs, and that cost isn't even captured. So in general, though they have led to small reductions in Medicare payments, I think most people agree that on balance, they've not been cost saving in the way that people had hoped. There's also, perhaps more importantly to the clinicians and patients who are listening in, there's been no evidence that these programs have led to improvements in patient outcomes. And so if we're really focused on reducing costs, we largely end up cutting post-acute care or the skilled nursing facility portion of these bundles. And I'm not sure that that's really a win necessarily. Certainly there's overuse of some post-acute care, and so decreasing that is reasonable. But the pressure really to decrease post-acute care has not improved outcomes either. So I think we've seen sort of suboptimal savings and perhaps even a growth in costs when you look not just at Medicare payments, really no effect on patient outcomes, and increased pressure on this post-acute setting that has been pretty problematic post-COVID.
So despite, or perhaps because of these setbacks, CMS recently introduced a new bundled payment program, the Transforming Episode Accountability Model. How will that program work and what types of care will it cover?
So, this new program, which has the, I would say, excellent abbreviation of TEAM, really focuses on procedures. So, the prior bundled payment programs, BPCI and BPCI-A, had included heart failure and sepsis and stroke and heart attacks, in addition to a whole bunch of procedural conditions. So, we're talking 30 plus conditions overall across these programs. TEAM is taking a much more narrow approach, looking at just a small group of surgeries, really. So lower extremity joint replacements, treatment for hip and femur fractures, spinal fusions, coronary artery bypass graft procedures, and major bowel procedures, or, big sort of abdominal surgeries. So it's a much more targeted and focused program than previously. The bundles are also shorter, so they're 30 instead of 90 days. And the big difference is that this one is mandatory. So rather than being a program where hospitals could decide to sign up, essentially to choose to participate in the program, in this case, hospitals are going to be required to participate in the program. And I think that's part of why it is narrower. And so it's really going to be a different test. It's testing if you force hospitals to be paid differently, do they behave differently? Rather than if you give hospitals the opportunity to participate in a program where they could save money, how did they respond? So it's taking it to a different place in terms of sort of the power of the program. I think we need to study it to understand the effects because it is quite different than the prior ones. But the big part is that it's only procedural, it's mandatory, and the bundles are shorter.
So you may have already answered this, but what elements of this new model could help advance payment reform and promote improved clinical outcomes?
The biggie is really mandatory participation. And I think that reflects CMS's belief that changing the payment incentives has a direct line to changing clinician hospital system behavior. I think that remains to be seen. That's really the big advancement, is moving toward the mandatory space, because again, we've tested these in a voluntary setting now for decades. So really the mandatory bit is the biggest. There's a couple other things that are slightly different about this one. One of them is that there are some design elements specific to health equity, which is extremely important because of a bad track record, I would say, for some of CMS's prior payment reform experiments to really overburden safety net hospitals. So we recognize there are hospitals in this country, due to a long history of residential, racial, and income-related segregation, where care for patients who may face a large number of structural and social barriers to having good outcomes, as well as the payer mix that can sort of support the broader function of a hospital, are not equally distributed. So there's hospitals around the country that we sort of colloquially refer to as safety net hospitals, though that's not a perfectly defined set. And those hospitals in many of these payment programs have really struggled. And so in this case, there are a few changes to the program to sort of recognize that it may be difficult for these hospitals who, again, face very different challenges in delivering care to avoid disproportionately penalizing those groups. Essentially, they have access to a lower risk track so that they would face lower penalties for poor performance. I think there's broader issues than that in terms of the payment targets and the way that things are calculated that need watching to understand, because we certainly don't want negative unintended consequences for these hospitals that are providing care to patients who sort of need them most. But that is one additional change to the program design in terms of incorporating a different track for safety net hospitals.
Finally, and more generally, what direction do you expect CMS to take for payment reform in the next few years?
That is a fascinating question, and one that I think, given recent political events, is actually pretty hard to answer, but I will take a crack at it. I think that in general, there's recognition that the complexity of the payment models that are offered to clinicians, hospitals, health systems has probably gotten too great. There are tens of payment models that clinicians can choose from. There's a dizzying mix of accountable care organizations and bundled payments. And when you throw Medicare Advantage on top of that, which is now more than half of the Medicare system, and all of the different payment models that plans are attempting also to sort of shift risk and reduce costs, it's really gotten quite complicated. And I think helped to drive the probably unfortunate levels of consolidation we're seeing in the healthcare system. So my suspicion, regardless of politics, is that there will be over the next, say, 2 to 4 years, some attempts to streamline some of this work. I think we really do need to think about burden reduction. So trying to harmonize measures across some of these models. Any model in and of itself can seem like a fantastic idea, but when you put them all together and they're pulling people every which way, it really becomes overwhelming. And there's more and more evidence about just the burden on clinicians, on systems, on infrastructure, the administrative costs. So I think in some ways, TEAM is an effort to simplify the bundles. It's a shorter bundle, smaller number of conditions, much more targeted, but it is yet another piece on this complicated payment landscape. So I think we will see some simplifying of payment. And I think that's an important thing to think about going forward. I think it very much remains to be seen politically what the goals are under the next administration. But from a purely policy standpoint, I think most people feel like it's the right time to think through how we might streamline some of the payment models that have been tried, learn from what works, and see where we can really push toward population health, better care, more streamlined care, more efficient care, but also try to not complicate the matter further by introducing 20 more payment models for people to work with.
Thank you, Dr. Joynt Maddox.